And you'll notice I had a panic when I noticed Bill sitting on the front row and realised I had not clearly stated on the front slide thunder. Just a small little place at the bottom to squeeze it in. It is hugely welcome, thank you. I was ever so slightly creepy actually, wasn't it? So we're going to talk about another group where the word inequality springs to mind. And this is part of a project where we've taken the needs assessment tool for progressive disease and cancer that David Curry has developed in Australia, and we've taken it, adapted it, and validated it for use of people with interstitial lung disease. So I'm going to present today the work in relation to the construct validation. So why? I think the bottom line actually says this: only 3% in an IPF registry report recently from the UK showed that these patients access palliative care. And I think no matter what definition you place on the word inequality, I think that ticks the box. Patients are highly symptomatic, a lot of them have a poor prognosis. It has been identified that there is particularly poor communication and coordination of care, particularly at the end of life. And despite this need being recognised and loudly proclaimed in policy documents, routine assessment of palliative care for these patients is rare. This is just to show some meta-analysis of observational studies we've just completed. And the top forest plot is about cough, and we'll see that the prevalence of reported, and this is routinely reported. I'd love to do a systematic prospective assessment of symptoms, and I suspect we will find these are all not higher. At the bottom is breathlessness. Interesting to see dysphagia starting to fill the reports there. And if you look again on other GI side effects like heartburn and regurgitations, that's the second one down, and the fourth down, it's a bit small, sorry. You'll see that these are highly symptomatic people. So I said we took the needs assessment tool, progressive disease and cancer. I started by saying, well, it is not. This is not a patient report outcome measure. It is a very different concept to something like the SPARC or palliative outcome scale. This is, I think, maybe the best way to describe it is a way to guide and help change the way non-palliative care specialists consult, is to try and encourage them to move away from a very restricted biomedical model into a holistic assessment and giving them an easy one-page psychometrically valid tool to help them do this in everyday clinical practice. Been developed and has been used by hospital-based oncology clinicians, and one of the key things it does is identify or distinguish between the concerns that can be managed by the non-palliative care specialist and those which need a referral. It's both got an identification of concern and maps to an action, which I think makes it distinctive, because I suspect all of us are a little bit fed up with yet another thing where we just document somebody's demise and do nothing about it. So, as I say, we adapted it for people with interstitial lung disease. I'm not presenting the face or content validation, and we're just about to look at the reliability testing, so this is the construct. Before I do that, just to let you see a little bit of what it is. So it has a patient domain, and this is the sort of thing which the clinician will be asked to think of. Does this patient have unresolved physical symptoms? And we had to change this quite a bit from the cancer tool, because the patient said it's respiratory to start with and then it's gut. Whereas, of course, in the cancer tool, it started off with pain. Now, we've also done this incidentally for Parkinson's disease, and the first thing they wanted us to ask about was movement issues. And then it goes through that checklist of unresolved psychological issues, problems with daily living activities, and then the sort of things which get overlooked and routinely forgotten in clinics. So spiritual existential concerns, work, financial, legal concerns. One of the things that came up when we were testing this was in the GP tool that we're doing for cancer, the GP said no one had clocked that this 72-year-old lady was the sole guardian for her grandchild, and nobody had figured this might just be a little bit of a problem when she died. So all they have to do at the end of the consultation is to think, right, there's either no problem, some potential, significant, and then it's who's going to deal with this? I'm going to deal with this myself, I'm going to refer to another team member, refer to specialist palliative care, and at the bottom of the sheet it acts as a referral sheet as well, where you tick where it wants to go, and there you've got that referral with the profile of concerns, so whoever gets that referral knows exactly where they're supposed to help. This is also one of the strengths, is not only does it look at patient, it systematically, integrally asks the clinician to consider the caregiver. Firstly, the ability of the caregiver to care, and then how are they? So methods. We trained ILD clinicians in 4 ILD clinics around the country, so Brompton, Manchester, Liverpool and Hull. Trained is a very loose, it took us 15 minutes tops. You can teach someone to use this tool very quickly. What we do need, we are working on implementation, and there needs to be training in symptom control and communication skills and how to work with your local palliative care team. But the actual tool itself is very intuitive, and it did not take a lot of time to train them. Consecutive clinic attendees and carers were invited to participate, and when there was participation and consent, clinicians conducted the consultation using the NAT as a guide, and afterwards the clinicians completed it, patients completed the St George's Respiratory Questionnaire for ILD, and the carers completed 2. They completed the Carer Strain Index and the Carer Support Needs Assessment Tool, because we needed 2 to make sure that all the constructs in the Needs Assessment Tool had a comparator. We calculated the sample size using simulations, using data from previous NAT cancer and heart failure studies, and the St George's data from ILD studies. And from that we calculated that a sample size of 65 would give 80% power to detect a relationship, a statistically significant relationship. And we just looked at the physical symptoms, and we had actually higher power for physical function. So we used the Kendall's Town B for the physical, for the patient well-being, and we used both Cohen's and PAVAC for the carers. We used the PAVAC as well for the carers because we had fewer numbers, and the range of different concerns we had were much more unequal. So we had 68, we actually over-recruited. We had such enthusiastic teams, but we sort of put that's never happened to me before. It was just amazing. I was still stunned with having over-recruited before the time. From the 4 sites, the ages are pretty much what you would expect for people with ILD, so we were pleased with their representative nature. Nearly 2/3 had, or about 2/3 had a carer, of whom about, just over half, bit more than half completed at least one of the assessment tools. And that was partly because patients would often come to clinic without the carer, and so then capturing the carer to enter the data was more challenging. I had 9 clinicians with a mix of doctors and ILD nurse specialists. So here we come to the results, as they say in the Eurovision Song Contest. I will not translate it into French as well, because my French is a bit lacking. I won't go there. So I'll just draw your attention. We did find statistically significant correlation, which is a relief. And overall, in actual fact, the tool was helping the clinicians to identify the patient's concerns. Of great interest, the clinicians were an awful lot better at finding problems with daily living activities, that is function, than they were with symptoms. And I'll come back to that in a minute. If we look at the carer domains, they were pretty good about the ability of the carer to care, less good about identifying the carer well-being. Partly of that was because sometimes the carer actually wasn't there, and so it was very hard for the clinician to make a direct assessment. But nevertheless, perhaps it speaks to our being less good at doing carer assessments, which we've already talked about, but perhaps we're getting better with patients, and we're leaving the concerns about the carer behind. In the face and content validation stage, we did some focus groups with the carers, and the incredibly strong voice with these carers was, our clinic needs this tool, because I sit in the corner and nobody speaks to me, and I'm wanting to tell the doctor or the nurse, I have real expert knowledge about this patient and you're not tapping into it, and I am on my knees and I think I am at the end of my rope, and I think I am about to crumple, and there will we be, and nobody's asking me. So there was a really strong view of how important it was that the carer and the patient were seen dovetailed together, and the carer not just as a co-worker, as a member of the team to care for the patient at home, but as a person with needs in their own right. So the comment, well, we've presented this before, people were saying, well, you've not got kappa values of 0.8 is no good. We were expecting something very much along these lines, because we are dealing with incredibly subjective and broad constructs. You know, we're not asking someone to rate, say, how do you rate the severity of this patient's cough? It's not. It's persistent physical symptoms. It is incredibly broad, it's incredibly subjective, so the fact that we were picking up this signal, we were pleased. The outcomes are assessed in the context of a busy hospital respiratory clinic, where in-depth assessment is not the focus of the assessment. This is about flagging up that person who has concerns and saying, what are we going to do about it? It may not be that we're going to do something about it now, but we need to be able to action something. We deliberately included clinicians with a very broad range of clinical experience, skills and confidence with some areas of the assessment and knowledge of the patient. And again, in the content validation focus group with clinicians, they put their hands up and they said, quite frankly, the thought of asking somebody not just about whether they're depressed or anxious, but as to their spiritual concerns, we have no idea how to get that. We need to be trained to communicate in this way. 10 to 15 minutes initial training, so of course, that was enough to get them started. There will be a learning effect in this, and we expect that the ability to pick up correlated concerns will get better. And our training did not include palliative care training or communication skills, although we know from our preliminary implementation work that this is what's going to be needed. So, in conclusion, we think we have a tool, the NAT PD-ILD. That's rather pleasing because the project is called NAILD, which is the needs assessment in ILD. You have no idea how many hours of project management group discussion that took. And that was our wonderful researcher, Carla Regova, who came up with NAILD. She said she didn't know it had come up with NAILD because she's Portuguese and had no idea it actually meant something. So we gave her the prize. Agreement is poor for physical symptoms and spiritual concerns in the patient domains, and this may identify that clinicians identify concerns with symptoms less well until they are so bad they are causing disability. And training to assess patient symptoms at an earlier stage may be a useful spin-off from using something like this tool. We've already identified that communication skills training will be important, and again in the caregivers section there was pretty good agreement except for 2 domains, and again this is likely to indicate clinician training needs. So thank you for your attention.